So I'm going to give you a little bit of a taste of a very practical application of using outcomes research. By way of financial disclosures, I have developed a few quality of life instruments, and those for-profit entities like pharma companies that want to use them do pay a licensing fee for which I get royalties and put back into developing more of these instruments. For academics who want to use these instruments, there's no licensing fee. So this is what we face in medical dermatology care. We sometimes have a problem in understanding what's going on because we can't really see the symptoms. We have issues with access that we'll talk about as far as time, space, and workforce. And then there is an issue of allocation of resources. We don't have infinite resources, and so we do need to make sure that we allocate them in a very evidence-based way. So this is the way it's supposed to work. You're supposed to have a full waiting room. Everybody is happy. People are just waiting their turn. They're not waiting too long. When you get them in the room, you have this nice dialogue, a one-on-one type of interaction, and everybody's happy. And if you use some sort of Yelp type of rating, you get the 5 stars, and you've helped them a lot and they're feeling much better. And your back staff office is feeling quite fulfilled and they're all happy too. So this is the way it's supposed to work. But as you know, it isn't the way that things work. Oftentimes there's quite a long time to even get into the clinic. And then we pack them in with all our overbooks. And so they're waiting in our waiting room for a long time. And then there is this thing called Epic in our institution. And so there's a computer in every room. And sometimes the patients are complaining, feeling like they're talking to a computer as opposed to talking to their doctor. And that computer follows you even when you go home, because there's a whole lot of charting to do. And so we spend a bit of time doing what I call pajama charting. And then maybe you're actually not making everybody super happy. There is some of those patients that you really are not addressing their needs. So this is probably more of the reality that we're facing. So where does outcomes research fit in? Well, I want to level set here and kind of put it into the framework of different kinds of research. Everybody's familiar with bench lab research. That's where a lot of discoveries are made. It gets taken to clinical trials, maybe. And then once it is FDA approved, let's say, then we have to take it out into real life to see whether or not in the real world it works. And that's what health services research is, or as some people call it, outcomes research, to see whether or not something that had worked in this very contrived microcosm that is clinical trials will work out into the real world. And why is this important? Even in the framework of all this research that we do, health services research is important because if it's not going to work in the real world, then it may be a big waste of time, space, and money. And so in order to judge whether or not we need to go back and iterate, or whether we should even go back and iterate, I think that outcomes research can be quite helpful with this. Now, again, the goal is to help patients on all these different kinds of research. The basic science research gets at etiology, pathophysiology, maybe further defining diseases with new biomarkers and whatnot. Clinical epidemiologists will take these tools and make diagnostic tests. They'll do risk prediction and also prognostic factors. And then the traditional clinical trialists will put things into trials. And we'll find out whether or not something is efficacious. And how do we do that? There are objective outcomes. And so in our world, something like the PASI or the EASY to measure objective outcomes. But now increasingly, there are subjective outcomes. And so those are things that need to be reported by patients. And this is under the purview of outcomes researchers. Effectiveness, I put in there because that's actually how well things work in reality, in real life, as opposed to efficacy, which is in the clinical trials world. And so trying to come up with tools so that we can make sure that these outcomes that we're using make sense is in the purview of outcomes researchers. And then health services research is when then all of the societal factors, whether it's social determinants of health, personal behaviors, the insurance type of structure that we have might influence access and cost constraints and the quality of care that we might be able to give. That's all under the study of health services researchers. So let's get to the meat of what we're going to talk about here today. And let's first attack the can't see the symptoms. And this is really where patient-reported outcomes are helpful. So this is the paradigm on the bottom right here. You see that guy with a back scratcher. He's probably not bringing in the back scratcher to your office, but that is otherwise his constant companion. And so these patient-reported outcomes, or PROs, might help you identify these symptoms and improve their quality of life. So why are patient-reported outcomes so important? Well, because there are a lot of things that just aren't visible. And for us, sometimes it's pain, but most of the times it's itch. That's really hard to measure, especially if you don't ask. And we really need to rely on patients to tell us how bad it is. Looking at the scratching, the excoriations, the evidence of rubbing, like in simplex chronicus or prurigo nodularis, really sometimes it's not a good proxy because people deal with their itching in various different ways. So I would propose that we use a patient-reported outcome, namely an itch patient-reported outcome where it's a self-reported severity. So this should be quite familiar to both patients as well as us clinicians because we have these pain scales. But one thing that I just want to point out is that in the itch world, until our group actually developed the Itchy Quant, which is this cartoon annotated self-reported itch severity scale, we didn't have something that annotated it with pictures. So with pain, there's something called the Wong-Baker facies, where they've got pictures of from very happy to tears. The Itchy Quant is something analogous to that so that people can sort of use these pictures to anchor what these numbers would mean. And fortunately, if you compare the Itchy Quant's behavior to the more traditional visual analog scale or the numeric rating scale, we have very similar bands. So 0 being no itch, 8 to 10 being severe itch, and then we also have mild and moderate itch here, so that if a patient tells you that they are an 8, you know you really got to pay attention. Whereas if they give you a lower scale, then you can sort of moderate the conversation based on that. The other type of patient-reported outcome comes in the form of quality of life. So there's lots of different ways of improving quality of life, certain freedoms, clean drinking water, the air that you breathe. But obviously what we're interested is in health-related quality of life. And I'm going to focus on one type, which is called a health status measure. Now, why is this important to measure it in this way? Because really us as providers, we're really poor proxies for rating patients' quality of life. So this is a paper that was published a long time ago, but us health services researchers often showed this graph or this table because it shows the correlation between physicians and patients. You want these numbers to be 0.7 or higher to show good correlation with the quality of life scores, and you can see these numbers are extremely low. So we as doctors really don't rate the quality of life impact of our skin conditions, especially these inflammatory ones that our patients are reporting. So you could use something like this. This is a skin-specific quality of life measure, so it doesn't matter what kind of skin condition you're talking about. And it has, for this version, 29 different items that then parse out into 3 constructs. You've got symptom-based questions, there's 7 of those, 12 functional or activities of daily living kind of questions, and then you have 10 emotion-based quality of life questions. And this is actually a big favorite of mine that Meg Kren developed. Now, those types of questionnaires are great for research, but you only have 15 minutes to see the patient. So it's really not practical to deploy those in the clinical world. So instead, what we need to look at are global measures that are short tools that would take not very long to complete and maybe even get them completed ahead of time before they actually come in for the visit. So Meg Kren and myself and my former boss, Bob Swirlick, we developed something called the SDOM, or the Standardized Dermatology Outcome Measure, so that we can integrate this into the medical record and it can serve as a vital sign for our dermatology visits. And it would be useful as data to capture nationally for population research. So this is what the SDOM looks like. Are you here just for a skin check? If yes, then they pretty much don't answer the rest of it. But if they have a skin problem, they have to list the skin problem, the main one that we're going to ask these questions about so that we know what we're actually looking at the data for. We ask the itchy quant to figure out whether or not they're itchy, and if so, how severe. And then this is the Skindex Mini. So we took that 29 item survey and we pared it down into 3. Essentially what we did was we put them into parentheses, these various different aspects of symptoms, emotionally bothered, and then these activities. And they can rank them from never bothered to always bothered. And then there are a few more questions about how would you describe your current skin problem from clear to severe? And then I think really importantly, is this good enough? Is your treatment good enough? It may not be clear, but is it good enough? And if so, I think we need to pay attention to that, as well as some of these side effect questions that round out the SDOM. This takes 5 minutes. We've timed it for patients to complete. And so this can be done on a tablet. Here at Duke, we actually send it as part of the MyChart messages. We have 97% of our patients that have signed up for the patient portal or MyChart. And so they all get a link to this survey and can complete it before they come in. Now, this is not a new concept. I showed this when I was at Emory. We were on Cerner at the time. And I had noticed I was supposed to collect this so I could continue my pajama charting. But I noticed that these words copyright kept coming up. And I realized these were copyrights for patient-reported outcomes. And so if I acknowledged that we were using this, then the patient-reported outcomes, they were not dermatology ones at the time, but that we would be able to use them. So if we are going to be able to use something like that, then maybe there could be a dashboard like this for all the patients that you're about to see. This is what the itch score is today. This is what the SDOM scores are today. And if this is a return patient, maybe across time, you can see what you've been helping. And in this patient's case, you're helping with everything else, but the emotional subscale is still quite high, especially in proportion to the rest. And so maybe you should spend those 15 minutes addressing the emotional impact. Now, the timing of the SDOM as a vital sign is important. I want to show you a real life scenario that happened to me. So I had a psoriasis patient that was itching and I put him on a biologic, and he came back in and his psoriasis was pretty stable, but he said, God, doc, this itching is just really bad. So I was starting to think, well, maybe there's a systemic reason for his pruritus. And so I ordered a whole bunch of labs. I put them into the computer, try to figure out maybe there's a systemic reason. I was getting ready to give him azathioprine. So I was teeing him up with our TPMT. And then I realized, wait a minute, I haven't asked him for his itch score yet. So I asked him, so on a scale of 1 to 10, 10 being the worst imaginable itch, where are you? And he says, oh, doc, I'm a 2. And so I canceled all the orders. I'm not going to go and spend all this money. I'm not going to put him on azathioprine, but I really focused on education of emoliation. The biologics were just not going to be enough. And then sure enough, it was no longer an issue as far as his itch. He came down to a 0. So if I had asked for the itch score to begin with, then I could have avoided a lot of work that I actually made for myself. I wouldn't have ordered the labs, and I could have just focused on really taking those 15 minutes. I can tell you that visit actually lasted a lot longer than 15 minutes, but I could have focused that on that education for topicals. So I do think that this SDOM could help us center what the discussion should be about. Now, in terms of access, we have a problem. We don't have enough slots in our ACGME to train enough board-certified dermatologists to meet all the needs of our aging population. In fact, we're going to be, and this is a little bit dated, one of these studies that one of my former residents did with me. we're going to be, 25% short of the estimated demand, and it's, I'm sure, higher than that now. So two things that I've been espousing is Telederm, as well as using advanced practitioner providers, or APPs, and integrate that into the program. So in terms of Telederm, the VA has done this extremely well. When the soldiers were returning from the Middle East conflict in 2012, the VA put a ton of money, millions of dollars, into telehealth, which resulted in store and forward, real-time video, as well as home telehealth. And at that time, it was perfect for us to do Telederm because the cameras were easy to use, the internet was robust enough to send photos. And so it got rolled out nationally across all of the VA integrated service networks, or the VISNs. And at that time, I was in Atlanta, and so we were VISN 7. This number of store and forward encounters has only grown since I made this slide. And so what would happen is a patient would come in, sees their primary care doctor, and the primary care doctor doesn't really know what to do about it. And so they sent them to an imager who took these beautiful photographs, and all of them had dermoscopy. And then it was attached to their e-consult, essentially, and sent over to our reading team. And we have residents who are part of the team, and it's a great educational experience. And so we assess the consult and the photos. We give feedback to the imagers so that if they don't take great pictures, we can give them some pointers. And then we give the primary care doctor some recommendations so that they can help us give it to the patients. And this became an incredibly efficient way of doing Telederm, such that we no longer just read out for these purple clinics, which was what fed Atlanta, but we eventually ended up reading out for the tri-state area because we were able to get this done quite efficiently. But as a health services researcher, I wanted to know, well, are the primary care doctors doing what we asked them to do? Like, is this working in real life? I mean, I think this is cool beans, but like, are they thinking that this is really cool too? So we took a look at that. And we took essentially 1,000 consecutive Telederm referrals. We found out, first of all, that our turnaround time was 1 business day. We were processing at the peak 500 consults in a month, all of which were done in 1 business day. And we were able to keep 2/3 of them in the virtual world, at least for a period of time. What we found out was that we were really, really good about having them get their follow-up appointment here. If you look at the green here, 98%, but that's because we handled the scheduling of that. So of course we knew what we were doing and when they were supposed to be scheduled. But if you look at the blue bars here, 50% of the patients did not need, or did need the meds, but 25% of them didn't get them. And 40% that needed reassurance, they didn't even get the reassurance that they needed. Some of these primary care doctors actually went to what we call a mini residency, and where we could teach them about some basic derm stuff. And those in our analysis were not more likely to follow recommendations. So that's not the answer to this. What turned it out to be the answer was to take more of a hybrid approach. So we took ownership of writing the prescription medications. We hired a Telederm nurse who would call the patient and educate them on how to use the medication, what the expectations were. And we gave the primary care doctor these letters that they could just have their staff mail out so that they can reassure patients, or they put them into the patient portal so that the patients can get them electronically. So again, we were able to improve access. We saved a lot of resources with that Telederm nurse. It turned out that 80% of those calls did not need to come back in. So we saved our most precious resource, and that is the in-person, face-to-face time for those people who really needed us. So what we learned from this is that we really need to build a good partnership with the referring provider. And COVID hit, and we couldn't take those pictures. They couldn't go in and see those imagers. So 2 things that we learned from doing it purely video. One thing is that we really need the photos. Trying to look at somebody on video without that photo was really, I mean, we got motion sick and it took us 20 minutes to get one glimpse. So that really was a waste of time. But having that interaction with patients was a really rich experience. And so the next step, what we did, by this time I moved to North Carolina, excuse me, we implemented a different kind of hybrid approach. And the reason why this works is because in the state of North Carolina, we get paid the same. We have pay parity between our telederm visits, video, with our in-person visits. So now, when a patient comes in, we schedule a video appointment. There are photos that are done, sent to us, and then we schedule the video appointment. And then if they need us to do a biopsy or whatnot, we have set up these acute care clinics, which don't open up until 2 weeks ahead of time, so they can come in and get their biopsy or whatnot. So we've been able to reduce our wait times. You can see here for the adults, we've come from 137, what we call our lead time, down to 78 days. We're still working on this. And then for peds derm, because we're doing it for peds, it went from 77 days to 55 days. So we're whittling away at our access issue with telederm. And the other thing is that you can see these orange and blue lines are starting to align. And that is because we are filling every spot. There's a very low no-show rate as far as the slots here for telederm. And so this is actually a great use of resources. And then plus we don't have to worry about the brick and mortar expenses. And then for those of you who are in leadership positions, we can also have data to show that we, what I call feed the monster, the direct contribution margins are what we're giving in terms of pathology for all the biopsies that we're doing from telederm and what numbers those turn out to be. And then we have other data that I'm not showing here as far as infusions and whatnot. Telederm definitely contributes to this downstream margin here that the health system benefits. So a quick word about APPs. So we have both nurse practitioners and physician assistants here at Duke. The difference between the two, for those of you who don't know, is really what they're trained to focus on. So PAs are focused to treat on the disease that the patient has, whereas the nurse practitioner are trained to treat the patient, to focus on the patient who happens to have the disease. At the end of the day, they're both delivering great dermatologic care. They start off in these elbow clinics where they're learning at the bedside. It's kind of like working with a student, and they're learning new skills, and they can expand the supervisor's capacity in this setting. Eventually, we graduate them to tandem clinics, so they still have clinics at the same time, but parallel to the supervisor's clinic. This can be a team approach, which some patients might prefer. And it again does improve capacity to see more patients. And then some of these clinics turn into independent clinics because they rarely have to bring in a supervisor. And these don't have to be at the same time as the supervisor anymore, as long as the supervisor is available. And again, this improves capacity. So in this model, we've actually also improved access to dermatology. And we're starting to look at some of those outcomes too, but I wanted to talk about allocation of resources and leave some time for questions. So when you ask a bunch of dermatologists and you tell them, I only have a certain amount of time, space, and money, then the first thing that comes out is, or maybe not the first thing, but eventually what comes out is, I take care of the sickest, most complicated patients, so I deserve the most rooms, I deserve the most staff, I need the RNs, and because I take care of the sickest, most complicated patients. Well, how do you know that? How would I know that that's what you do? For instance, we might have two different kinds of dermatologists here. And, they say, I treat eczema. I treat the worst eczema. So the first group does on average maybe one biopsy, orders a few labs, uses a lot of topicals and codes a level 2. The second group does a ton more biopsy, orders a lot more labs, not only uses topicals, but starts using systemics. Maybe is starting to think about biologics or coding at a level 3, 4, maybe even 5. So if you were the person making decisions, trying to figure out who you want to hire, who you're going to give resources to, who are you going to favor? And normally, if I were in person, I would ask people to raise their hand, but that's really hard to do in this setting here. So I would say that for those of you who picked one or the other, you actually don't have all the information. There are two different populations that are coming in. One might be more bread and butter, and one might be much more refractory because they've already seen 3 other dermatologists. So really, you are comparing apples and oranges here. And what we need to do is to level the playing field when we're comparing our provider types. So to do that, we should do something called risk adjustment. And so what you could do is for this, what I call bland, you don't know the difference between their complexity level panel of patients, you could put in a risk adjustment tool. And one of my former residents helped me make one such that you can assign a score so that you can say, well, these patients are low complexity, these are high complexity, and the rest are medium complexity. And then you can start allocating resources appropriately with that. So this tool actually should be quite familiar with you because we actually based it on CMS's medical decision-making paradigm. At that time that we were putting this together, it was before 2021, and so we weren't really using this a lot. But this is now something that should be quite familiar. But what we did in our paper is we put dermatology examples into here so that people could use that paradigm much more carefully. And so we have the levels of risk, and then prescription drug management. And we had, when we published this, we had a psoriasis across 3 different complexities. So 3 different types of psoriasis patients that you could be either minimal, moderate, or high complexity that we pointed people to. So what we did with the next step was when I moved to Duke, one of my medical students actually used some Python programming and tried to do this in a more automated way. Because the last thing that I want to do is to ask the physicians to do more clicking and more work to get a score. And so he tried to do this in an automated way. We got a pretty decent kappa. Again, we want to aim for 0.7, but 0.4 is actually pretty reasonable. And so now we're in another Shark Tank type of competition so that we can get some AI support to use some natural language processing to get this kappa higher. And if we're able to do this, then other people can use it. And then we can assign our resources in a much more data-driven sort of way. We can also work with our APP schedule because they really shouldn't be seeing the most complex patient. We should make sure that and this sounds very trite, but it's really the right patient to the right provider at the right time. And we can do this in a very data-driven way. So again, this is how it's supposed to work. We really want to increase access. I would suggest that teledermatology and using APPs in a very appropriate way should be done in this way. We just recently had a Grand Rounds talk about private equity and their usage of APPs. That is not what I'm promoting, and I'd be happy to talk about that more. I also think that we should incorporate patient-reported outcome measures into our workflow. Again, that SDOM, we've put it into our Epic. And of the people who got it, we actually are at a 60% hit rate now, just by sending out the link without any nursing touching it at all. And so we're quite excited to see what that data completion looks like. And then I would say that we really do need to, as a field, really start thinking about risk adjustment. And hopefully this tool that we've developed here could be part of that conversation. But we really need to own that narrative as dermatologists and not rely on non-dermatology policymakers to make those decisions for us. So I know I spoke pretty fast, but I did want to have time for some question and answers. And I just want to acknowledge my funding sources here throughout the years. And I'm happy to take any questions.
Hey, Suephy, this is Rich Gallo. Thank you very much for speaking to us today. It was great to hear the talk because it spans so many different things between, practical patient care, scientific analysis of outcomes, and then the politics and all of this is involved. So it's great. I kind of wonder your thoughts about, long-term goals to integrate subjective data from patient-reported outcomes, which are incredibly useful, but also can be so subjective with biomarker assessments, and make kind of better validated tools that are hybrids of both.
Absolutely. So I think that we are really at a cusp of getting the right data, right? So I know that at UCSD, there's a big biobanking initiative, and I truly believe that not only should there be specimens collected, but the patient experience at that moment in time that that specimen was collected should be an important part of that data that's collected. Because if you take that sample and you're looking at all these inflammatory biomarkers or whatnot, but the itch score was a 2 as opposed to a 10, like that would be kind of important to know, right? So what
Exactly.
that
Yeah.
patient is experiencing, I think, is really valuable because it's only what you're seeing with your assay is only part of the picture there. So I do think that we're really at a point in time where these are validated tools, right, that we can put together. The other piece of this is data derm, right? So the Academy has the National Registry that they're really pushing hard. The academic centers are slower to come because of the lawyers. But I do think that to collect on a national level what the patients are experiencing and linking that to other data. I don't know if you can biobank nationally like that, but as we develop ideas for better predictive models, I do think that having that kind of data collected nationally would make a lot of sense.
Thank you.
Sure.
Do we have any other questions? Let's see. There's someone in the audience. We're just handing over the microphone. I guess you can't probably see us here in the dark.
Can you hear me?
No.
Do I have to push something? No. Hi, I'm Laura from the VA, and we are instituting Telederm at the VA here in San Diego and trying to align reimbursement for the time spent, especially and the extra time trying to get patients into clinics that need to be seen more urgently as opposed to those that we can just manage. I think does not seem to be standardized in terms of allocating resources and payment for that, at least at our institution. So I just wondered how you manage that at yours.
You're talking specifically at the VA, or you're talking about outside the VA?
Well, my experience is specifically at the VA, but you can address it either way to help.
Sure. So at the VA, I mean, as with all VAs, like we're salaried at the VA, right? So there really isn't an incentive as far as more revenue per se, but capturing that work is super important because that translates to more resources coming in. So I just kind of want to level set with that. What we ended up doing was building the landing zone, is what I call it. So having our acute care clinics, which only open up 2 weeks in advance, is how we've managed to make sure that patients can get in so that, because we've already essentially triaged them on Telederm and we need to get them in a timely manner. So for those patients that really, it's irritated seborrheic keratosis, I tend to just give them a little bit of triamcinolone, but if they really need to come in, it just doesn't have to be urgent. But for the ones that I'm looking at that are melanoma, that I'm worried about, then they can get in next day without overbooking a clinic because we have these acute care slots. And those are just like regular clinics, so that we are still, earning the work RVUs and whatnot, whether or not that translates into additional revenue, or if that just makes the argument that you need more resources like at the VA. Did I answer your question?
I think so. Our scheduling team, as of now, doesn't know how to integrate those new acute clinics that come up 2 weeks before we've requested that. So maybe I can reach out to you at some point to see if there's a way I can use that as a preface for our schedulers to be able to implement a clinic like that. Thank you.
Sure. Yeah. Just one thought about that. The VA is a little harder to do that because they're very set with their algorithms and sort of their culture there. Really, the key is to freeze those slots and then to be able to have them thaw automatically. Really, is the best way to do it in a time frame that makes sense.
Thank you.
Sure.
I had a question about the SDOM that you're sending out by MyChart. I think that was really great to see all that data. And I was wondering, when you send that out and it comes back, is there someone who has to compile it, or is there some way that you can have that automated that would collect that data for you?
So the data are being collected on the back end. We actually have a dot phrase that our vice chair of clinical ops showed me how she did it. So I'll steal it from her. And so if I put that dot phrase into my note, then the SDOM that was completed for that particular visit will populate into my note. So I can see that ahead of time, like how they scored, and I can use that to inform the decision or the conversation, I should say. The Holy Grail, where I could see trends over time and that sort of thing, we're not quite there yet. But I have a researcher who wants to use these data as part of her research. He's going to be part of our analytics team, the Durham part of it, working with the Duke Epic team to be able to pull out more raw data for her purposes, which is research, but that might help us build a more custom dashboard.
Yeah, I thought that was really amazing how you were able to separate out the symptoms, emotion, function. And I think it really did point out things that we probably wouldn't see in a normal visit.
Yeah, I mean, I think all of us, are trained to really get good HPIs. But sometimes, especially in a really rushed setting, where maybe the patient is just not as forthcoming because it's, you're sitting there prompting them, having a set of questions that's easy for them to answer, it's amazing actually what comes out. I mean, some of my colleagues at Emory are using this, and it's just amazing what is coming out. Like people that you wouldn't expect to be itching are like itching.
I think there's one question in the chat from Dr. Dubé. I don't know if you could see it.
Oh,
It
yeah.
says, yes. Do you have any data regarding the 60% of patients who complete the SDOM? Was there a difference between age? Was it worse in the elderly population?
Yeah, you read my mind. This is hot off the press. We don't know the phenotype of those patients. I'm really curious about that too. So stay tuned. I think that's our next step, is to figure out which of our patients. All of our patients get it except for the ones that are going to Mohs. So I don't know if they're kids, if they're elderly, if it's our hospital-based clinic as opposed to our satellite clinic. I honestly don't know. So it'll be really interesting to see that.
Thank you. I think one additional curiosity I have is, whether if they complete it, 2 days before versus the day of, what's the concordance between the two? Like if you repeated it in the office, is it the same? How much heterogeneity is there?
Yeah, that would be interesting, although I don't know if they would tolerate completing it so many different times. And as somebody who measures the responsiveness of these instruments, with the exception of itch, usually the symptomatology and the functional impact doesn't change that quickly in that kind of time frame. So I would be surprised, but you're right. I mean, we wouldn't know until we actually asked that.
I had actually one other question about the pediatric population, because you showed that data with the telederm improvement, which was very, very impressive. But looking at the difference between adults and peds, it looked like there was a little bit of a lower rate of improvement in the pediatric population. And I was wondering why, because it seems like telederm for peds seems like it would be a great and easy thing to do as opposed to a spot check or something like that, or total body check. So I was just wondering, why was that number lower in the
I actually think
pediatric
it's
population?
because of the time of day that we're doing this. So what I would love to do, although I have to find somebody who will help me do this, is to partner with the school nurses and to have those school age kids be able to use recess or lunch or something like that, go to the school nurse's office, and we would have our telederm. And obviously we've got a conference in the parents too, but Zoom makes it so easy now, and to have that discussion, because these are school age kids that are not coming in. They're not severe enough that it's worth missing school. Like, for those of you who are parents, like you just give your kids some Tylenol and send them to school, right? And so it's not bad enough for that. So I really think that we have to figure out the school age piece. We are hiring also some people who are very interested in after hour or after school hour, I should say, visits or before school. So I think those two things would be interesting to implement and see if our uptick is higher.
Yeah, I think that'd be great for the pediatric population. Those are all great ideas. So let us know how it goes.
Yes, for sure.
Okay. Oh, one more online question from Dr. Tom. Are you able to see that, or do you want me to?
Yeah, suggestions on how to better determine complexity of condition prior to first visit. They see multiple derms on systemics. That's right. Yeah. So the tool that I showed you, Dr. Tom, you're very astute. I'm hoping the Shark Tank people don't recognize this, but the tool that we showed really is best for return patients. But we do have referrals that referring providers have to complete in order for them to come in to do dermatology. So the next step would be to harness those online referrals that they have to put in and to be able to feed a comparable tool to better triage. And they may not be as comprehensive as far as the information, but we should still be able to get something from them so that we can triage better. And you're right, like multiple derms should be part of it.